time. So I'd like to invite Dr. Deepak Agarwal and Dr. Krishna Kanta Roy to be here on the stage. So this will be basically a session where we will deal with certain tricky situations or difficult situations and some easy tricks and tips to kind of tide over the situations. So the first, we will have a slight change in the order, primarily because there are sessions that are clashing for some of the presenters and speakers. So first, I would like to call upon Dr. Anirudh Maiti to speak on managing complex TRD in PDR.
A very good afternoon. At the outset, I would like to thank Dr. Devdulal Chakravarti for giving me this opportunity. Well, I will be speaking on the management of the complex diabetic TRDs. So there are some tips and tricks to deal with this complex situation. Can I have the sound? So the basic thing is the segmentation and the delamination. This is a case you can see it's a tabletop tractional detachment covering entirely the posterior pole. Can we have that switch off? So the most important thing in the dissection of the diabetic TRD is to find out the age. As in this case, we have picked up the age. Once we detect this age of this membrane, we can gradually dissect from the surface of the retina. And obviously, this is the conformal cutter delamination. We have to go along the shape of the eyeball. We have to be very careful not to touch the retina and create a iatrogenic break. And especially in the posterior pole, if you create a iatrogenic break, it will be a complex situation. So gradually, we need to be very careful in picking up this membrane with the cutter itself and then clearing all the membranes. We need to be very meticulous in the dissection in taking care of all the membranes. And now flushing of this triamcinolone acetate to see whether there is residual vitreous left behind. And after doing so, we have put BBG so that I can peel the ILM, because you can see there's a little bit of puckering also left behind. And now that is the situation. Now the other process is a bimanual dissection. This nowadays we do much less. This is a very old video of mine. Putting the chandelier's light, and this is the tractional detachment. These are the situation where it is very difficult to do with the cutter itself. So we need to put the chandeliers. Sometimes we do put in 6 o'clock as well as 12 o'clock. And then with the forceps and scissors, we need to meticulously dissect this membranes, and we need to the basic things like remains the same. The plane we need to dissect, and with the scissors we have to give small snips to delaminate the membrane. It can be an inside out delamination, or it's better to be depending on the situation, you decide whether it is better to go from the inside out or outside inwards. Obviously the PVD plays a role, and the snips which needs to be given is a very small snips so that this membrane can be dissected from the retina. We need to be extremely careful in this situation, because if we are in the deeper plane, we will create an iatrogenic break. And once we have released the membrane, we have to cauterize the bleeders so that it doesn't rebleed, and do a very good PRP so that we prevent the bleeding. So this is one procedure that is a proportional reflex. This features has been there in the Constellation machine, and this actually has reduced our bimanual technique. What is that? It is the fluid is injected in between the membrane and the retina, as it's shown in this animation, and the membrane is elevated from the surface of the retina so that we get a plane of dissection. So once we detect this plane we can easily take out the membrane without injuring the underlying retina. As you can see, this is a very bad membrane on the nasal sides. Generally, the nasal side membranes are pretty bad. And we have created a plane so that we can do the dissection. And then the fold back cutter delamination can be done. Take out the bleeders, cauterize the active bleeders. As the tractional membrane is gone, so the little bit of fold which is there will gradually subside. So the take home message with this newer technology, proportional reflux, and the better visibility, we can give a predictable outcome even in the advanced diabetic retinal detachment. Thank you.
Thank you, Dr. Anirudh for dealing this in such a small time.
Yeah, sometimes it is so adherent. This procedure actually helps us to bring up the age. Once the age is been detected, then the dissection becomes easier. And the other procedure, what we can do is visco dissection. We can put in visco in between the membrane and the underlying retina. But in that case, it is a little bit risky. Sometimes it can create a iatrogenic.
Nice presentation, sir. I have one question. So in the era of 25 days vitrectomy, so how frequently are you using scissor and forceps?
Now that's what I was telling. Nowadays we don't use this bimanual technique much, but there will be cases which is if this patient was a one-eyed patient, you cannot take a risk. This extensive membrane, still we need to depend on this bimanual.
Another thing, sir, which gauge you are using? If you are using scissor, 23 gauge or 25 gauge?
All 25. We are not using 23. This video is quite old one.
I'm actually asking one thing because in 25 gauge the curvature scissor length of the scissor blade is very less. So that and curvature also very less. So
nowadays, although we are using less, we can manage the dissection because we are using all 25 actually. 23 we are rarely using.
One thing here is in eyes that have a lot of sclerosed vessels and thin retina. One should have a very low threshold for converting it into a 4-port surgery. So once you are you see the retina is not very healthy, so convert it into a 4-port surgery, and you can even use your cutter as the scissor, and hold the forceps in one hand and put a light pipe in the 4th port, and you can do a much faster surgery. I see Professor Ashim Ghosh sir here, so if he has any comments on this, because we'll let Dr. Maiti go.
Thank you, sir. I asked only on what is the prognostic factors by which you can decide this type of complex surgical maneuver? Ultimately, the patient will get vision how much? I want to know from you because you have many experiences of doing surgery in this series. Definitely, I want.
I think in a surgical case, obviously keeping apart the systemic factors, when the patient comes with this extensive diabetic TRDs, extensive fibroscopal proliferation, the main role for a surgeon, as far as the surgery is concerned, to dissect all the membranes, to do the best what we can do. And obviously, in many cases, doing the best also, we cannot revive the vision. The target of this surgery should be, we should approach the patient as early as possible. The visual prognosis will be better. Because the more advanced, yes, we can manage surgically, we can give an anatomical settlement of the retina, but functionally there doesn't do much correct.
Thank you.
Would you like to do SRF drainage in our SRF drainage?
If there is no rhegmatogenous component, SRF drainage is generally not done, but yes, in some long-standing diabetic TRD, sometimes we do to take out the thick fluid because that hampers the settlement of the retina. But in general speaking, if there is no rhegma, we will not drain the retina because we have released the traction, it will go back by itself.
difficult to find out the plane. So what will you do? What's your approach?
Yeah, that's what we were just showing, that we have to dissect and pick up the plane. The plane, if we cannot do it with the cutter, generally what happens, we clear the vitreous, and after doing the PVD, very controlled PVD, not a very forceful PVD, we can find out, we have to look out for the edges where it is elevated from the retina, from where we can start the dissection. If we can't do that, we can at least find out an area where we can do this proportional reflux and make out the plane with the visco proportional reflux or a visco dissection.
Thank you so much, Dr. Maiti.
Thank you,
And, we will let him go, and there's been a call just.
Very good afternoon. Thank you, Dr. Devdulal Chakraborty, and thanks to AIOC for this opportunity. Actually, my topic is on failed macular holes, where we have already operated, and there has been we still have a refractory macular hole. We have operated once or twice, and we don't have an ample amount of ILM to peel, and the whole, and as we know that once it has been operated and it has failed, then the hole tends to be even larger than what it was before. So in these kind of situations, the only thing that we have in hand is an autograft, a retinal autograft. So my video will actually deal with the hurdles that I have faced in my journey while I was trying to do autografts, but finally the last video will be one complete surgery where we have tackled all the hurdles. So the first hurdle is how when we harvest the graft. As you can see, I've put the PFCL and that is the graft area. So often I'm trying to lift the graft, I'm trying to dissect the graft with a cutter, and then after 360-degree dissection, it is occasionally difficult to lift it up. Again, there's another situation where the graft is quite adherent at its site and it is a little difficult to manipulate it, and we must remember that there's also PFCL there, so it's a little difficult maneuver to harvest the graft. Okay, now finally I've been able to harvest it. Second hurdle that often we face is if the graft floats above the PFCL. Now ideally it should be below the PFCL. Here there's another situation where the graft is, I'm trying to chase the graft and the graft is merrily moving around on the PFCL bubble. It's quite like a Tom and Jerry chase. Yeah, finally I'm able to like corner it and then tackle it down. The third hurdle, as expected, there might be hemorrhages at the graft host site that can be tackled with adequate amount of endocautery. Now, once I've got hold of the graft, grafting can be difficult sometimes. I mean, implanting the graft. Here, we must again remember that there's PFCL, so the graft is sticking to my ILM forceps or sticking to my max grip forceps, and I'm trying to remove it, but I can't. Finally, I could. Again, another situation. So actually, we can do it with the forceps. We can do it with a silicone tip cannula. We can also do it with a tenos scraper, a diamond dusted scraper. Here I'm trying to do with my forceps. Finally I could. Graft size should be adequately around 1.2 to 1.5 times larger than the hole. So as you can see, I've grafted quite a larger graft. I've taken a quite larger graft. So what you can do is, initially if you have, you can put the graft and then you can trim the edges. so that it comes to the adipate size of 1.2 times the size of the hole. There, I'm trying to trim very carefully. There is a risk of eating the whole graft off, but we have to be careful. Again, another situation of a graft loss. This was during my initial days where I used to do hybrid vitrectomy. That is, my right hand side port was a non-valved one. Now, after I faced this, I had shifted myself to a completely valved ports. All the ports were valved. So what happened here was, my right hand port was non-valved one, and the graft was floating on the PFCL. And the moment I removed my right hand, there was turbulence, and before I could realize, within a split second, the graft flew away. And I could never find it out. So I had to harvest another graft, as you can see here. The graft is gone. So I'm harvesting another graft beside the first graft. Another situation that can happen is, once I've put the graft, everything in place, I'll end the surgery now. I'll put silicone oil and end the surgery. The moment the silicone oil comes, it drives the graft away from the junction, from the hole. This is what's happening now. There, my graft has flown away. So with the silicone tip, I'm again trying to take it into the hole. Finally, I could manage. So it's basically, as you can see, or sometimes it can be a steeplechase race, providing various hurdles. But yes, you can tide over the hurdles if you are aware of the possibilities that can happen, and if you are ready to take them head on. Usually I do a barrage laser all around the graft area. Thank you.
Sir, excellent presentation, sir.
Thanks, sir.
One or two questions, sir. What I saw, like when you are harvesting the graft, means when you are separating the retina from the choroid, you are using the cutter at the margins.
Yes.
So what is the cutter that you keep at that time?
That should be as high as possible. Highest cut rate.
Highest cutter.
Yeah.
And have you done any cases where you have made such a graft in cases of RD cases, RD with macular hole? Have you done any cases?
No, I haven't. Why? I'll tell you. Because usually an RD with a macular hole, usually what we see is, once you have settled the RD, what I maximally do is, I do an island peeling. And up to date, all the cases that I have done, if you have done the island peeling adequately under PFCL, I do all my islands under PFCL. Once the RD closes, the hole closes. You know, at one point of time, we used to do refractory macular holes. We used to create an RD.
Yes.
That was one way of tackling refractory macular holes. You used to create a bleb and a RD so that you can mobilize the sort of immobile retina so that once it settles, it closes the hole.
Right.
So that same thing acts over here. The RD per se, once it settles, it will close the macular hole if you have done a good island peeling.
Why I asked was because I had a case with it was extremely complicated case with RD with choroidal detachment with macular hole.
Oh, okay.
So I did a RD surgery, drained the choroidal fluid and did a island peeling.
Okay.
But unfortunately the patient, although the choroidal size is resolved, but there is a recurrent RD.
Okay.
So I was just like asking you if this can be done in this case or not.
Of course you can do it. Of course you can do it. No, but I would suggest that you always have a second time when you are doing a silicone oil removal, right? So because you have a choroidals over there right now when you are operating.
Choroidals are not there right now.
No, when you had been operating the first time, there was CD, right? There was choroidal detachment. So might be little dangerous to do a graft over there at that point of time, because already you have a boggy choroidal. So if you land up with a macular hole, you can of course tackle the macular hole when you are doing the silicone oil removal. Now, if I face that, I would rather go for that.
Just if I can add a point, just to pick up from where you left regarding inducing a retinal detachment to like settle or close recurrent macular holes. So this is something similar, something which I'll be showing. But having said that, in what is the logic behind creating a macular detachment in case of failed macular holes to close it? You are trying to mobilize the retina. So in an RD, MHRD, macular hole with RD, you have a situation. Let's just leave aside, bad myopic, posterior staphylomatous RDs. Other than that, if you have a myopic, if you have a macular hole with a retinal detachment, believe me, it's going to close. And let me stick my head out and say that using a soft tip cannula, you can drain finally from the macular hole. What that is going to do is it's going to oppose the macular hole edges and bring them closer, and this will be some kind of a healing by primary intention almost. And this is based on a publication I'm going to show, which we have published, and another is coming up. And this is because there is evidence that in failed macular holes, if you do a detachment around the macula and you drag the edges, you can close the macular hole. So in macular hole with RD, do everything, and you can drain with a soft tip cannula from the macular hole. Be gentle with a low IOP, something around 30 or less, and then be gentle, give it some time, drain out the fluid from the foveal region, from the macular region, and it's going to close. And you will have a vision of maybe 636, 624, which is, I think, in a MHRD is fair enough.
One thing I would like to add, sir, seeing one of your cases where you were injecting the silicone oil, and while injecting the silicone oil, the flap,
the graft flew away. Yeah, it moved away.
I had some difficulty similar, not exactly similar, but very much similar, because we do some macular hole cases where the patient is residing in a hilly areas. In those cases, I'm not able to give a gas into these eyes, because they can't stay for 1 month or so somewhere else. So they have to go to their native place. So in these cases, I'm forced to give silicone oil for these cases. And so what I do is after the ILM peeling and inverted flap, I'm injecting a silicone oil. So at 1 or 2 cases, even these flaps tends to get dislodged from the holes. So what I'm now doing in these cases are I direct the silicone oil at the optic disc.
Yeah.
And then it gradually covers the.
It flows slowly, gradually flows over.
So this can prevent such.
Right. Yeah, I mean that's what I'm saying. You learn the hard way. When this had happened only one time. So next, I do exactly what you said. I direct it in a different way so that it doesn't fall directly on the graft, and the graft doesn't fly away.
There are some reports also of using a viscoelastic drop of viscoelastic fluid on top of the graft and then going for a slow injection of silicone oil.
Yeah, I've tried that with a free flap.
Right. Yeah. So if there are no more questions, we'll let Dr. Mandal go, and thank you so much for this beautiful presentation. Next up, we will have Dr. Sneha Jain. Again, she has a presentation elsewhere, so we will break the queue and let her in. Old RD in macular hole with subretinal bands. So that's a tough one, and Sneha did the job. Welcome, Sneha.
Thank you, sir. Okay, so I'll start. Very good afternoon to all. I'm grateful to be a part of this august gathering. Quite young in the field of retina, and this is one of the challenging cases that I've encountered so far. So going on to the case, this was a case of a total retinal detachment with a macular hole where a subretinal band was seen extending from the superior quadrant and making a U-turn at the optic nerve head. On its way, it was passing right under the macular hole. So the challenges in this case were tackling the subretinal band and also dealing with the macular hole. So after thorough vitrectomy, meticulous base shaving and marking of the peripheral breaks, it was imperative to deal with the subretinal band. because this would not only prevent the retina from settling but also hinder in the macular hole closure. So a retinotomy was made just above the band in the superior quadrant, and with the forceps I'm now trying to pull the band, but as you can see it keeps slipping back into its place. So then I went on with a bimanual approach, trying to rope out by grasping and re-grasping the band. The intention was to remove as much of it as possible. But in this tug of war between the band and me, it snapped right in the middle, leaving a significant length which was traversing the macula. Now, if this would have been left as such, the retina would have settled, but the band would just slide under the hole, interfering with its closure. So to tackle that, another retinotomy was made in the nasal quadrant, went in with my forceps, grasped it near the optic nerve head, and this time the entire band came out, coincidentally taking the shape of its symbol O. So the universe was with me now. So one hurdle crossed, time to take on the next one. That is the macular hole. So I stained the ILM with BBG and then tried to do the peeling under infusion, which I have done in few cases. But in this case, the retina was just too mobile, even after draining through the retinotomies. So after a few futile attempts of trying to peel, decided to take the help of PFCL. So the PFCL bubble was injected, and now with a more stable macula, I could go in for a pinch and peel technique. Did manage to get a small peel, but was unable to continue peeling. So tried other sites to get a flap, but failed due to the poor staining of the ILM. Again, I decided to go and restain the ILM under PFCL. So the ILM was painted with the dye, and after removing the excess dye, I got a beautifully stained canvas to work on. So with better contrast, I could get the flap and peel with ease. So the ILM was basically peeled all around the macular hole up to the edge of the hole. And I want to do an inverted flap, so kept a flap of the ILM on the hole to close it. So the PFCL did help as a third hand, and it helped in doing a very easy ILM peeling. So once the job of the PFCL was done and the ILM peeling was completed, took out the PFCL bubble, initiated the fluid air exchange to settle the retina, and drained all the SRF through the retinotomies. So once that was done, a good Paris laser was done, not around the retinotomy, but also around the primary breaks which were there in the periphery. And after a final fluid air exchange, and once I was satisfied with how the retina was settled, I concluded the case with a silicone oil tamponade. So I just like to say that don't take every challenge as a problem, but every problem as a challenge, and we can all overcome whatever life throws at us. So the tips that were there in this case was basically not all subretinal bands need to be dealt with, but the ones which will interfere with your surgery, they need to be removed. PFCL is a savior. It does act like a third hand. So use it whenever it is necessary, and do not hesitate to restain if necessary when you're dealing with macular holes. Thank you.
Beautiful presentation, Sneha. And one thing I really liked is that you had a very low threshold for bimanual, removal of the membrane, subretinal membrane. And one thing that's in this situations, many a times the retinal break that is there, or created retinotomy that is created for removing the subretinal band, it usually expands. So it's a good way to do a handshake sort of a technique. And there's also a technique called the spaghetti technique by late Dr. Forlini from Italy, who was a regular in VRSI and many of our AIOS meetings. And so it's like you do with spaghetti, you just roll it up, and I'm sure Sneha uses a lot of that too. Or otherwise, if the position is such that you can't do a spaghetti technique at that particular position because of restrictions of movement, you can always do a handshake technique, and with which is of course bimanual, going to be bimanual, and remove the subretinal band, which is going to save the day for you. But having said that, very nice surgery, and with, like you mentioned, with PFCL, ILM removal in macular in a detached retina becomes so much easy. Dr. Deepak?
Right, yeah, excellent presentations. One small tip which I can give, like there was nothing you could have done more in this case because the band was through the macula. But otherwise, if it's a large band at the periphery or at the
Doesn't
periphery,
need.
you should make the retinotomy at the middle of the band. That
Right.
will really help you to take out the entire band at one go. And yes, I was about to say about the spaghetti technique, as rightly mentioned. That really helps. Otherwise, excellent presentation. Anything you would like to comment?
I want to add something.
Yeah, sure.
Regarding that silicon oil thing. We can also use a light pipe. Instead of just directing it on the optic nerve head, initial part, if you just use your light pipe and direct the silicon oil like you do for your stains, initial 1 or 2 drops, if you like, when you're injecting and you don't have the glass syringes, then you can just direct it on the light pipe itself so that the initial force is gone.
Right.
Same thing for the silicon oil. If we have something which will dislocate,
Yeah,
because yeah.
direct impact.
So for example, I had one optic nerve head pit where I use a thing, and then the thing just pops up and all the flap. So usme sir was just one visco drop, and if you direct your silicon oil on the light pipe, it helps a lot.
Great.
Small tip, but very important tip that you mentioned. And many a times when we restart fluid after a fluid air
Right.
exchange, we've had situations where the retina breaks.
Yeah.
So it's very important to gradually start the fluid start the fluid after air fluid exchange, and it should be at a low IOP, maybe something around 15-20, so that will prevent any breaks in the periphery. It might seem harmless fluid, but you can create breaks or micro trauma. So
I normally use the light pipe there also.
Absolutely,
I do around
yeah,
the infusion, right?
yeah. So and very nicely. When we inject, dyes also, you can use your light pipe to sort of cushion the. Yeah. So thank you, Dr. Sneha, and we'll let her go. And next up is Dr. Deepak Agarwal. He will actually be speaking on behalf of Dr. Abhishek Bose, who could not make it due to some emergency at home, and he will be speaking on CNVM with macular hole. So welcome, Dr. Deepak, who is a prolific surgeon based in.
So I'll be speaking on behalf of Dr. Abhishek. I'll take this opportunity to present my video on double trouble of fluid and flap. So no financial disclosures pertaining to this particular talk.
Double trouble of fluid and flap. A 65-year-old lady presented with dimness of vision in both eyes. Best corrected visual acuity was 2/60 in right eye and 6/36 in the left eye. Fundus of right eye shows pigmented lesion at macula, while left eye shows whitish macular lesion with exudates. OCT right eye shows scarred CNVM. Left eye shows CNVM with cystoid edema and subretinal fluid. left eye intravitreal anti-VEGF injections were started. But after the third injection, there was resolution of VMT with formation of a large full thickness macular hole. Challenges in the present case are a one-eyed patient, already diseased eye, difficult intraoperative identification of macular hole, and ILM peeling to be done over CNVM. After detailed discussion with the patient, surgery was planned. Vitreous stained by triamcinolone. Posterior vitreous detachment induction was done. Vitrectomy completed. Brilliant blue dye injected. Internal limiting membrane peeling was initiated. The plan is to do an inverted ILM flap. Things were going really well when this happened. The ILM flap got dislodged from the hole margin. Now PFCL was injected. ILM free flap was made. Using silicone tip, this free flap was positioned in the macular hole gently. PFCL was removed. Fluid air exchange performed. Postoperative OCT showed closed macular hole with BCVA of 6 by 36. The learning points in this case are: intravitreal injections can cause resolution of VMT. The VMT resolution may lead to a macular hole formation. ILM peeling is a viable option for macular holes in CNVM. Keep calm and carry on after an intraocular complication. Free ILM flap can be tried in dislodged ILM cases. Thank you.
Thank you, Dr. Deepak. Very nicely shown, surgery. And just one thing here is, what happened after? Did the CNVM come back? And how long follow-up you have?
Very fortunately, for last 3 months, there has been no collection of fluid. Interretinal fluid is not there. Very small pocket of SRF is there. But as per the guidelines, the recent guidelines from the European Society also, we are tolerating some amount of SRF. We are not injecting for very small amount of SRFs.
Right. So one has to, carrying on from your mention about SRF. If the SRF is coming back and if it's increasing, then obviously you need to re-inject. But having said that, in a lot of situations where you've done a like surgery, VR surgery for some other reason, which had a CNVM or developed a CNVM subsequently. When a subsequent CNVM develops, then there is no doubt about injecting anti-VEGFs. But if it's a patient with a CNVM that has developed something like this and surgery has been done, or retinal detachment has occurred and a surgery has been done, what one sees is God gives us a time of maybe 2 to 3 months time wherein the CNVM doesn't come back. So and then one has to be very careful. You have to do your OCTs every month, and the moment you feel that it's like reappearing, it's recurring, then obviously you have to re-inject anti-VEGFs. So any other questions from the audience?
I have one question. Deepak, great presentation, obviously.
Thank
One thing, when you are putting that ILM flap in the hole, so if you are using soft tip, obviously it may little bit damage that underlying RPE.
Yeah.
So what on that? Can you use forceps in that?
Forceps to do what?
To place that ILM flap.
Forceps can be tried, but since as also shown by Dr. Soman Mandal sir, at times what happens is when you are using a PFCL, so these flaps, this retinal flap or an ILM flap might float onto the PFCL. So that becomes extremely difficult to reposition it again. So what I have done in this case, and I will, if needed, I'll do it again if in such cases. So what I do is that after generating this flap, I only drag it very gently. It has to be very gentle, of course. Very gently, it has to be dragged below the PFCL to the holes. If you are using a forceps, first of thing, below the PFCL, you are not able to use that very much, and there is always a chance of injuring the retina, underlying retina. So rather than using a forceps, I will personally like to use a soft tip. But yes, the opinions can differ. I feel much safer with the soft tip.
The point you have raised is very pertinent, and I would like to agree with Dr. Deepak that it's better to use a soft tip here. But with a flute needle, if it's a soft tip with a flute needle, tagged onto a flute needle, often it can happen that the flap can enter the flute needle. So the one way you can do away with this problem is load your soft tip needle onto a 1cc syringe with a stopper, that is with a plunger that is fully closed, and so then you will not have any ingress of the flap into the soft tip cannula. So that is something that can save the day for you.
One more tip to do so also is that you can keep the vacuum very low, and other thing is that in a fluid needle there is an opening. There is an opening from which we do fluid gauge assay. So you can close that opening with your thumb.
Absolutely. Yeah,
that will in majority of the cases it will prevent this egress of the flap through these holes. If you have closed it, there is no pressure difference. So if there is no pressure difference, the flap will not enter the tip.
Absolutely. Yeah, sure. Yes, Neha, please.
If we can use a diamond dusted forceps which is old.
To be very frank, I have no experience with diamond dusted. So if you are comfortable with that, that's okay. But I have no experience with diamond dust. I have never used it.
There are publications using old diamond dusted Thanos, like yeah. You can use that, but there shouldn't be any diamonds there. So thank you, Dr. Deepak. He will again come back for his own presentation, but meanwhile, I would like to invite Dr. Subhendu Boral, Senior Consultant at Disha Eye Hospitals, Kolkata, and he's actually, he's presenting elsewhere in this SFO session. So he will be speaking next, and his topic is submacular hemorrhage, how to manage, learning from the master himself. He has a lot of publication on submacular hemorrhage, and this is something that we've probably all read and know about. So welcome, Dr. Boral.
The pleasure is ours, sir.
So good afternoon, everybody. Like my topic is submacular hemorrhage, my approach. So management options are many, starting from introduction of TPA, assisted subretinal blood removal, which was first described by Dr. Payman et al. And multiple options are also there to treat the significant submacular hemorrhage, starting from intravitreal RTPA, intercooler gas, vitrectomy with subretinal TPA, intravitreal TPA, removing the blood with creating small retinotomy, or doing relaxing retinectomy, a large retinectomy, or using the RP colloid patch transplantation. We should know what are the principal causes of subretinal hemorrhage. It is this, what a treatment strategy actually depends on the. I am talking about the neovascular AMD, post neovascular AMD, or PCV induced vitreous hemorrhage. Not talking on the post traumatic vitreous hemorrhage or something else. Treatment strategies depends on the size, duration, distribution, and these are three principal factors. And height of submacular hemorrhage at fovea, it is also, it has some doubtful role. Generally, I am following this kind of algorithm. I am working for last 10 years. Small size hemorrhage less than 4 diameter, you can treat with anti-VEGF, pneumodisplacement, or intravitreal TPA. But if it is more than 4 diameter, you have to treat it surgically. So if it is confined to the macula, I am coming one by one. Like this is the small size, one less than 4 diameter, less than 2 weeks duration. So anti-VEGF, pneumodisplacement works better in case of myopic CNV with submacular hemorrhage. Like another factor is where I am treating it surgically, that is more than 4 diameter and more than 2 weeks duration, but less than 4 weeks duration. And it is confined to the macula, extending more to the inferiorly, and 2 to 4 weeks duration, where I am using the non-drainage technique, that is vitrectomy along with cocktail injection of subretinal TPA, anti-VEGF, and air. And finally, SFCS gas component you can get. And you can, why I am using TPA? TPA actually, it is available in the normally in our eye. That is the factor is responsible for spontaneous resolution of hyphema or vitreous hemorrhage that occurs naturally because of natural coexistence of TPA inside the vitreous cavity or in aqueous humor. But we are using recombinant TPA, that is the antiplase or retiplase or technetiplase that is available to treat embolic or thrombotic stroke. But in this situation, to lyse the submacular hemorrhage, we are using it for the more clot lysis. The usual dose is, I am restricting myself less than 100 microgram, usually 50 microgram. Like in this case of submacular hemorrhage, where I am after doing vitrectomy using subretinal and PVD induction, using this subretinal needle, polytip needle, and directly introducing into the submacular space and waiting for some time. Then again, after waiting for 5-10 minutes, you are injecting this anti-VEGF subretinally, and followed by anti-VEGF, and as well as the filtered sterile air, and finally do the fluid exchange and SF6 gas tamponade. So you can get good kind of result like this. Like in other examples, you can see the submacular resolve submacular hemorrhage after this treating with this vitrectomy with subretinal cocktail injection. So now coming to another category, significant submacular hemorrhage, more than 2 weeks duration and more than 4 diameter, where it is extending beyond macula, and duration is 4 to 8 weeks. So subretinal TPA followed by removal of the subretinal blood, that is, it is a drainage technique either by retinotomy or retinectomy. So if you are doing a retinotomy, like in this case, vision loss was more than 1 month duration, where I am just after doing the vitrectomy, I am injecting subretinal TPA for the clot lysis and making the retinotomy for the subretinal blood removal. If it is adequate enough, you can make one retinotomy, or if it is not adequate enough, remove all the bloods from the whole subretinal space, so you can make another retinotomy, like in this case where I made it in the supratemporal quadrant, and to remove the blood as much as possible. It is not mandatory to remove the all blood, but some layer of blood may be there at the end of your surgery. You can wait and it will be spontaneously resolved. So finally, you can inject gas or oil tamponade depending on the sites of retinotomy. And postoperatively, you can see good improvement. Finally, sick patient vision was 6/12 after silicone removal and ERM removal, because ERM was formed. Like in this case, where the vision was dropped vision for more than 6 weeks, almost hemorrhagic retinal detachment, you can see it's almost ora to ora serrata. It is not only the extent, but also the duration is very important, where I'm injecting subretinal TPA, waiting for some time, and then doing the temporal retinectomy after waiting for 10 minutes. You can wait more also depending on the duration, the amount of clot, and remove all the subretinal blood, and using PFCL to settle actually you are creating therapeutic GRTs and doing then reposition of the retinal flap and doing laser all around and ultimately silicone oil PFCL exchange, injecting silicone oil with the left hand, removing subretinal this thing PFCL with the right hand under Sandler's light. And postoperatively, you can see beautiful result after 10 months of surgery after silicone removal. You can get 6/36 vision like this. Now coming to the more devastating situation where it is more than 8 weeks duration. So submacular blood removal along with RP choroid patch graft transplantation, like in this case, it is a 3 months old subretinal hemorrhage. It is almost black colored, and you can see the amount of blood. It is so much of extensive, where must be some kind of like RP is totally compromised, where you have to replace the subretinal RP choroid patch graft transplantation. So blood was almost clotted, and it was very difficult to remove the blood as well as the subretinal CNVM part. And practically, it is most difficult part is the CNVM part because it couldn't be removed. It is very difficult to remove this subretinal CNVM part. Now I'm choosing a relatively healthy area of RP. From where I can use the RP choroid graft, injecting subretinal PFCL to keep the retinal flap away from my working site under Sandler's light. I'm using curved scissor to get the graft, and under the PFCL you can reposit this graft bimanually or with the help of forceps into the proposed site of fovea, and then you can then you can reposit the whole reposit the whole retina using removing after removal of the subretinal PFC. You are introducing over the retina, reposit the retinal flap, do the laser all around, just like to treat giant retinal tear, and do the all around the laser barrage as well as the graft site, and do the silicone and PFCL exchange under Sandler's light, like my previously described silicone and PFCL exchange. So postoperatively, these are the few more example of this successful surgery, but not always it is successful. Maybe I should say it is 55 to 60% case you can get the good result, although vision will improve to and patient will gain ambulatory vision from PR inaccurate stage. So we have already published our first article, that is long-term clinical outcomes of submacular blood removal along with isolated retinal RP choroid patch graft transplantation in this Indian experience. And second, it is going to be published within, I think, in the month of June. Real-world outcomes and complication of different surgical approach of significant submacular hemorrhage. And in this article, I describe all the algorithm chances, because stray incidence of like some big amount of submacular hemorrhage can be resolved with simple intravitreal TPA, or you can inject any anti-VEGF like long-acting ranibizumab. I'm not criticizing anybody. They are all stray incidents, but if you follow this kind of algorithm, I think you will definitely gain some kind of success. You may or may not agree with me, but still it is what I'm working for last more than 10 years to gain this kind of algorithm. Thank you.
Thank you, Dr. Boral. I think wonderfully presented, and this is a tough area where actually one has to realize that the best kind of vision that we are going to get is maybe between 636 and 618 at the best in the worst kind of scenarios. And these are patients who are in a hopeless situations, many of them one-eyed. So whatever vision comes back, ambulatory vision is good enough for the patient to, tide over the next phase of his or her life. So I think it was a wonderful presentation. So any questions to Dr. Boral, because I'll have to, let him go for his other, commitments now. So in case there are none, then I would like to request Dr. Krishna Kanta Roy with his presentation on ERN removal. So this is going to be a basic presentation on ERN removal. And Dr. Krishnakanta is a VR consultant at the Divita Eye Institute at Durgapur, and he's a prolific VR surgeon, and having done his fellowship from Shankar Nitralaya under Dr. Dhanashri Ratra and others. So welcome, Dr. Krishnakanta.
Thank you, Dubul sir, for the opportunity. Today I am going to discuss ERM removal from a young surgeon or beginner's perspective. So before going for surgery, we have to plan the surgery and pre-operative assessment. So in that, pre-operative OCT is very important. As a few ERM, they are very loosely adherent, very easy to peel, whereas few membranes are there, they are very much adherent to the retina and very difficult to peel. In these cases, choosing the peeling instrument is very important, as the for initiating that ERM peeling is required much more force. So using forceps is a better idea to start the ERM peeling. Second, in few cases we can see that ERM margin very well. Like in the first case, here you can see that ERM margin and which is slightly elevated, so it is very easy to feel. But in second case, it is very difficult to see the margin of this ERM. So this is correspond with the intraoperative findings, intraoperative fundus findings. So here we can see the margin very easily. We can start the peeling, but here it is very difficult. So here we can use another multimodal imaging like blue reflectance. As you know that in blue reflectance, from the blue reflectance, we can use that superficial retinal structure very well. So both the cases we can see that ERM margin a little bit more clearly than the fundus picture. So here actually we can see the delineate that margin of ERM. So some cases this multicolor imaging also little bit help us to see the find out the margin of ERM. Second, if its cataract is there, especially posterior subcapsular cataract, we have to remove that. And instrument, yes, we have to use that. Now the era of 25 gauge, we prefer to use the 25 gauge instrument. And viewing system, yes, we can use the biome and contact lens both, but contact lens have little bit advantage over the biome, that contact lens give us a better visualization, more magnification, and especially in myopic patient, using instrument with biome is a little bit difficult, where contact lens help us. Third, in high myopia, if a patient has high myopia with epiretinal membrane, in that case choosing instrument is difficult, is important. We have a membrane peeling forceps and a scraper. Scraper have a little bit more rich than the forceps because length is a little bit more. So we can start the surgery from scraper. Now this is vitrectomy. So in vitrectomy, actually we start do the core vitrectomy. After that we induce the PVT with help of IVTA. Though 70% cases if PVT was there, but few cases vitreous is very much adherent to the over the membrane. So we have to take care. We have to pull gently. Next. Visualization aid, we can use some stain like triamcinolone or Milan blue dye. So Milan blue dye give us a negative staining. So initiation the peeling. So we can use two instruments. Like previously we used other instruments also, but right now we are using mainly these two: membrane peeling forceps and membrane scraper. So membrane peeling forceps mostly we are using for where we can see the margin, where it is a little bit difficult to start the peeling. But a scraper, which is a ERM is very thin, and we cannot not very much sure about the margin, and especially for the beginners to prevent the damage of underlying nerve fiber layer. So in forceps, we normally use pinch and peel technique. So align the forceps over the edge of the margin, then we first pinch, lift and release. So this causes loosening of the epiretinal membrane, like you can see here, and after that again we pinch and make a flap, and then we pull that flap tangentially along the retinal surface. We should not pull vertically over the retina. So we have to pull that flap along the retinal surface and maintaining the curvature of the eye. And second thing is we have to extend the flap circumferentially, like we do capsular excess in cataract surgery. Otherwise it causes break in other area. Now this is the pinch or peeling technique. So we first pinch, release, and then again we pinch, then we start peeling. So here one nick is there, then we can see the margin, we can hold the margin of the ERM and we start peeling, and gradually over the retina and circumferentially. And another thing, we have to hold multiple times. We have to see one go, we should not go that, we should not remove the membrane entirely, that may cause break in other area. So this is another video, same thing. We first pinch, release, and then again grab and make a nick over the membrane and hold that margin of that membrane and gradually start the peeling over the retina. Here we can use membrane scraper. So cases where we cannot see the margin very clearly or we are not very much sure, especially for the beginners, we can use the scraper. With membrane scraper, we can move over the membrane and make a flap so that is little bit elevated from the retina. Then we can hold it with forceps. Now I am holding it with forceps and try to peel, like pitch and peel technique. Now ILM peeling, it is a little bit controversial to ILM peel or not. Yes, it is multiple papers show that ILM peeling does not improve the functional outcome, but it decreases the recurrence chances of recurrence. So in most cases we do ILM peeling. So after staining with brilliant blue dye, so you hold that ILM. Already the nick is made and it is elevated from the surface. Then gradually, like ERM peeling, membrane peeling also done. So in summary, preoperative assessment with OCT is important. Sometimes we can use help of multicolor imaging also. Yes, visualization with triamcinolone brilliant blue dye is good, which help us for surgery. And initiation of peeling with forceps or membrane scraper can be done, but continuation of peeling done with forceps. And ILM peeling normally we do with forceps. Thank you.
Excellent presentation, sir. For the sake of time, we will take the questions and later if we are left with some time. Now I will request Dr. Devdulal sir to give his talk on extra large macular holes, doing it my way. Sir is a senior vitreoretinal surgeon at Desai Hospitals, Seraful.
Be presenting this. This has a volume sound thoda kar dijiye.
Macular holes are caused due to anteroposterior traction created by the vitreous, and once they form, they gradually enlarge due to the tangential traction caused by the internal limiting membrane. We have also come to know that contact of the vitreous fluid with the hole edges causes thickening and eversion of the hole edges. Let's now take a look at the evolution of macular hole surgery. Kelly and Wendell described vitrectomy for macular holes in order to take care of the anteroposterior traction. Success was good at around 70% hole closures. We looked for something better, and ILM peeling helped us reduce tangential traction, increasing the success rate to over 80%. There was the use of autologous serum, etc. in between to close macular holes. And then came the inverted flap technique, which helped in closing larger holes, the explanation being facilitation of glial proliferation. Today, perhaps the inverted ILM flap technique is the most commonly used technique for larger macular holes, but we still have type 2 closures and open holes. Considering the facts, we describe in this video a modified technique for the closure of large macular holes, where gentle massage of the retina, superior and inferior to the hole, was performed using a 27-gauge soft-tipped cannula. As seen in the animation, this maneuver causes approximation of the hole edges, followed by drainage of macular hole fluid, finally leading to better hole closure. This is a 70-year-old lady with an extra large macular hole having a vision of 360. ILM was stained using BBG. We initiated ILM peeling with a 25-gauge ILM peeling forceps. We took care to remove a large area of the ILM. We ensured that ILM was completely removed from the margins of the hole. We performed fluid air exchange, gently massaged, and mobilized the retina superior and inferior to the hole. Finally, it was time to drain the fluid from within the hole. This led to further approximation of the edges of the hole. This is the post-operative OCT. Vision had improved to 636. In our series of 41 consecutive cases of large macular holes, we adopted this simple and reproducible technique of drainage and massage for mobilization of the retina, leading to good results. To conclude, a wide initial ILM peel and gentle massage and mobilization of the retina utilizing the 27 gauge soft tipped cannula followed by macular hole fluid aspiration facilitates bringing closer the edges of the hole, thereby ensuring proper closure of large macular holes.
Thank you.
Excellent
Thank you all for your kind attention. So if there are any questions, I'd like to take.
Yes. Will we take now? Should we?
Or yeah, you can finish your
Let's complete the
presentation, yeah,
sessions.
because we don't have much time here.
Now, I would like to invite Dr. Deepak Agarwal. Deepak is working in Siliguri Greater Alliance Hospital. He is a prolific surgeon. So he will be talking on scleral fixation of IOL.
So I'm here to speak for myself. The previous talk was given on behalf of Dr. Amitav, and this is my personal talk. So I'm going to speak upon the scleral fixations of IOLs. This is the technique which I have learned from my mentor, Dr. Shubhendu Bural sir, and this is my experiences. These are all the surgeries have been performed by me. So I have no financial disclosures pertaining to this talk. So after a complete vitrectomy, we do small peritomies at 3 o'clock and 9 o'clock, followed by cautery. Now a curved paralimbal scleral flap is made approx 3 millimeter away from the limbus, and the flap is extended to approx 1 millimeter towards the limbus. And the sclerotomy is being performed with a 25 gauge trocar. Similar process is repeated on the other side. It's extremely important to make sure that the two sclerotomies are absolutely 180 degrees apart. In all my cases, I use a multi-piece foldable IOL. So these are the glued forceps IOLs by Dr. Amar Agarwal sir. The foldable IOL is being injected. With a weighting haptic, with a weighting forceps, I catch hold of the haptic. It's extremely important that you hold it at the edge of the haptic, and the haptic is externalized. Now I insert the forceps from the other side, and using a handshake technique, I use the other forceps to guide the haptic to the forceps which is using from the sclerotomy site. And thus both the haptics are externalized. Now we create a scleral tunnel. Mind you, initially it was a scleral flap, now we are making a scleral tunnel with a 26 gauge needle which has been filled with dye. The dye is injected for better identification of the tunnel, and very nicely and very gradually the haptics are fed into these tunnels. The similar process is repeated on the other side. And in the end, it's a very nicely stable, centrally placed SFL. And in all my cases, after placing an SFL, I do go in again and give a thorough examination of the retina before closing the case. Thank you.
Do you use glue to kind of close the peritomies, or you cauterize?
No, sir, these are glueless surgeries.
These are glueless surgeries. Okay. And have you had a problem with the haptics once in a while? Number one. Number two, do you use the same kind of like IOLs, or you have different brands that you use?
Not to name any brands, but we are using the foldable multi-piece IOL of a very high quality brand, and in majority of the cases we are using that particular lenses only. In very rare cases where the patient is not affording, then we can also place a rigid IOL. I have placed rigid IOLs, but that is in once in a while. Say if I am performing 50 surgeries of foldable IOLs, maybe 2 of the patients have rigid IOL as well. But it's more easier to use a foldable IOL with a multi-piece foldable IOL.
Deepak, nice presentation. Regarding bands, actually, what happened in our hospital, 2 bands only available. So I am telling the name also because facing the difficulty. So one is Alcon, another is sensor. Right now, sensor is not available. Availability is very issue. But with Alcon, their haptics are very much flexible. So sometimes what I can getting, I am also doing similar to this procedure only. But sometimes the haptics little bit bend, or the curvature with the optic a little bit change. So position of the optic little bit deviated from one side. Sometimes it's happening.
It used to happen in the initial part of my surgeries when there was a learning curve. As sir also asked that whether there was any problem with the haptics. Yes, initially when I was doing my first or second case, maybe up to the 5th case as well, at times the haptics used to come off. But after doing some amount of surgeries, they are not doing so any well. Because once you are doing this, you come to know of how much traction to pull, with what force should you pull, and to be best with your own hand, but gradually you learn. So to be very frank, now I'm not facing any trouble with haptics. They comes out very easily, and yes, at times if you're not catching hold at the tip, it should be caught at the tip. And if you're not catching at the tip, then you might have some curvature of the, again, there is a particular curvature and then it might turn again. So that happens if you're not catching at the tip. And even if you are catching a little further away from the tip and it bends, you can always cut it. You can always cut it. If the haptics are very large, but you should not cut to a very large extent so that there is nothing left to put it into the tunnel. And majority of my cases remain stable. At least I have 18 months of follow-up, so none of the case has shown any major deviation or any major tilt of the IOL till now.
Actually, stability is not issue. Issue is astigmatism. IOL is little bit deviated from one side.
Astigmatism is often there in most of the cases. If you are getting an astigmatism, say up to 1 or 1.5, that's acceptable for SFLs. Yeah, if you are getting an astigmatism up to the 3, if the astigmatism reaches 3 or more, that is always a cause of concern. But if you look at most of the studies which has been published, and even in your cases, if you look into that, majority of patients do have an astigmatism of say -1, -1.5. Very fortunate patient might end up with astigmatism of 0.5 or something. But yes, some amount of astigmatism is always there.
Regarding the placement of the IOL, to quote our teacher, Dr. Pramod Bende sir, a 7-degree tilt of the IOL is acceptable in case of SF IOLs. So that is something that one has to keep in mind. Regarding the choice of IOLs, the more you do with any particular type of IOL, it becomes like your kind of cup of tea basically. Because since you mentioned two names, one is not available at this point in time with us. Most diopters are not available, whereas the other one is available. So initially it was to save costs. The sensor IOL, multi-piece IOL was available at a lesser cost to us, and we passed it on to the patients. But subsequently, all diopters of sensors is not available at this point in time, sensor multi-piece. So we are almost exclusively at Disha, we are doing with the Alcon multi-piece lenses. No interest financial for me or any of us in Disha on this. But gradually, we found that this works as well. And it's important to realize that, you have to have a sufficient amount of the, haptic to tuck in. Only in pediatric cases, you can cut off some of the the part of the haptic in case you feel it's a very long haptic. Otherwise, in most cases, with the Gebor's carrier technique or whatever technique you are following, including your technique, so basically you can tuck in the IOL and this tuck in the haptics. And the important part is the tip of the haptices should not be exposed. So, but of course, then there are controversies regarding this with Yamani's technique. You just sort of leave it subconjunctivally, or not always. I have seen that it stays within the scleral tunnel. So this is probably, the jury is out on this. Yeah.
No, conjunctiva, just as we do for this SICS cases, we just cover the flap with the conjunctiva. Yeah. Yes. See, if you ask from a very much from a vitreoretinal point of view, we will always say that yes, base dissections we do in all the cases. Because whenever you are entering from the sclerotomy site very close to the vitreous base, there can always be a pool, or even while you are taking out the vitreous from the vitreous cavity, you are taking out the haptics externalizing, there might be an additional pool which can cause tear, unfortunate tear, and it can lead to RD. And these patients, they want very good vision, because initially they were going for a cataract surgery only. This is a, I feel it's necessary, but points may differ. We are doing it.
I think you have the best of both worlds. You moved on from being a prolific phaco surgeon to a VR surgeon, a prolific one at that. So like now it's your take. But for a lot of the cataract people who cannot do a complete surgery, then basically one has to ensure that there is no vitreous that's going to come into the haptic, or the where you are taking out the haptic from. So basically it's a good idea for them not to go in through the anterior segment corneal section for the vitrectomy, rather going through the pars plana, because most phaco machines have vitrectomy equipment now, and you can make two trocar cannulas and do a excision of the vitreous as far as possible up to the region where the anterior segmentis surgeon is trying to take the haptic out from. So I think that part is very important. But having said that, for us VR surgeons, a complete vitrectomy is what we've been taught, and that is what should be done ideally.
One thing which can be done, like if you are reluctant to do the entire full base dissection, what can be done is that where you are making the sclerotomy ports, those areas should be done, like their base dissection has to be done in that part mandatorily, because once in a while you can end up with a RD after SFL.
Yeah, that's what for VR surgeons it's easy, but for an anterior segment surgeon without the endo illuminator, and it becomes difficult. So thank you, Dr. Deepak. I think we are impinging on the time of the next. Yeah, sure. Initially, for this publication, before this publication, we were doing it after the fluid air exchange, but now we have realized that doing it before the fluid air exchange opposes the retina much better, and then you can finally do a fluid air exchange and drain the fluid. So that part is to be done obviously after the fluid air exchange, but you can massage it before you do the fluid air exchange, so it works better. And for this, one of our presenters showed the high mag lenses. I think you showed the high mag lenses. So these are available from various agencies or instrument manufacturing companies. So even if you are doing non-contact vitrectomies, like you are using a biome or something of that sort, so it's a good idea to use a high mag system which is self-stabilizing, and do that part of the procedure using that high mag system. So that will ensure good success, very good success. Thank you all for listening in.
Thank you.